Hello everyone, myself Nanda Sadakat and I have been associated with MyAussieTutor and academic writing since the past 1.5 years. And I have a bachelor's in dentistry and a master's in public health. And the topic that we are going to discuss today is about critical care nursing. What are the ethical and the legal issues as nurses and as healthcare professionals we face while providing critical care to patients and their families as well? So let's begin. First of all, what are the ethical issues that the nurses face every day? It will include informed consent, the issue of giving consent and having informed consent from patients after describing the procedure, withholding or the withdrawal of treatment of any type, then organ and tissue implantation, transplantation, whether we need to do it or not, whether it's possible to do it, confidentiality maintenance of the patient and the patient's family and the details that have been provided, or whether the patient wants his health details to be hidden from his family, or the family wants the details to be hidden from the patient so that not to disturb the patient. So it can work in either way. So it becomes an ethical issue. Distribution of healthcare resources, whether we should provide it to which patient if the healthcare resources available are limited. So who should it be given to and who it should not be given to. Then using advanced technology as life-sustaining treatment, whether the people want life-sustaining treatment to be given to them or whether they do not want them. So that also becomes an ethical issue. Then greater frequency in critical care, greater frequency of patients coming up in critical care and getting themselves treated. So nurse advocacy, the basic idea of nurses to advocate is to basically obligation is for protecting patients. Therefore, they should serve as advocates for patients in the healthcare system and healthcare organizations. The professional organizations that promote ethics and advocacy, when we look at the situation from this aspect of United States of America, is the American Nurses Association, the ANA. And they have a code of ethics for nurses with interpretive statements, and the American Association of Critical Care Nurses specifically, which provide an ethic of care and provide some guidelines to help nurses in advocating for their patients and protecting their patients as well. So what is the ethical dilemma, warning signs that are there when it comes to nurses handling situations like these? That is, the situation is emotionally charged, or there is a confusion about facts. There is also a significant change in the patient's conditions from what the patient had initially decided that they want to do. And now when the patient's condition has significantly changed, then it changes the situation and the response that we are supposed to give to that. Then hesitancy about the correct set of actions that need to be applied, deviations from the customary practice, and need for secrecy regarding the proposed actions. So, what is the protocol or the procedure that must be followed while making ethical decisions? Is as follows: that there is specify the ethical dilemma that exists and assess the following factors in relation to the ethical dilemma that exists. That is the contextual factors, policies of the institution, the resources, the relevant law and the ethical cases, and the societal and the economic issues associated with it. Physiological factors such as the nature, status, and the likely course of disease progression that happens, the imminence of death, the occurrence of death, the symptoms and suffering. The personal factors, competence, the stated wishes, goals, and hopes, definition of the quality of life, family relationships, and support associated with the same, with the ethical dilemma. Then consider the healthcare options in the light of autonomy, that is the patient's own wishes and goals. Then the patient's principle of beneficence, that is burden, whether it is acting as a burden for the patient or providing some benefit to the patient. The associated relevant ethical principles associated with the specific ethical dilemma, and then the potential outcomes of the various options around the ethical dilemma. Therefore, then a plan of action must be developed with the patient, the family, the surrogate if the patient has appointed any, and the healthcare team, whatever is appropriate. And then that plan should be taken action upon, and then it should be evaluated for its short-term outcome, its long-term outcomes, and also its applicability to other cases as well, whether the plan is applicable to other cases or not. So the ethical principles that need to be kept in mind are autonomy, that is the patient's right of self-determination to its own care that he is getting concerning his own medical care. Beneficence, that is you are to prevent any harm that might happen to the patient, remove any harm that might happen to the patient, and promote the good of the patient. Non-maleficence, and not to intentionally inflict any harm to the patient. And justice, that is fair distribution of the healthcare resources so as to provide appropriate treatment to the patient. Veracity, that is being absolutely truthful to the patient, situation of the patient, the healthcare situation, and handling of the situation. Fidelity, that is being faithful to commitment towards the patient and its healthcare. Confidentiality, respecting the right of the patient and his family or either ways to protect and control information associated to the patient and his health condition. So what is the level of involvement of the nurses while this ethical decision making is being done? Basically, the level of involvement of the nurses is basically towards advocacy, that is you are open to communication to discuss the patient's wishes and ethical concerns to the other healthcare team members, and also collaborating with the other healthcare team members regarding the same. And also dilemmas can result in moral distress. Therefore, the formal mechanism is that a bioethics committee or ethics consultation committee is made so that formally the approach or the decision is made. The other opportunities that are available for critical care nurses to do this ethical decision making is the institutional ethics committee membership, or having ethical forums and rounds to discuss cases that happen normally, so that you are able to react to the situation that has come towards you. Review journals, other people's reviews or statements about that. Quality improvement committee membership also, and institutional review boards as well. The duty to treat, nurses are required to care for the assigned patients, that is the contractual relationship, and abandonment as well, that is severing the professional relationship when patient is in need of care, and also ensure that patient care is arranged with another nurse, including breaks and lunch, etc. When you're not there, so there it's arranged with another nurse. Moral conflict, nurse is not required to practice if a situation violates his or her moral or religious beliefs. It is easy, you can say no. A nurse can say no if it is violating her own religious beliefs. And patient care must be transferred to another, so that the abandonment is avoided when there is a moral conflict with the nurse's approach and the situation of the patient. And at those times, the patient should never be abandoned, but the care should be transferred immediately to another to avoid any situation of abandonment arising from the same. And nurses should approach situations that result in moral conflict. How should they approach situations that result in moral conflict? Either abandonment, either leaving and transferring care, or being able to practice still, even if it's violating personal moral religious beliefs. So what are the selected issues? First is the element of informed consent. That is, there is competence, ability to understand the situation. Then voluntariness, in which the consent has been taken from the patient without coercing the patient that you have to do it, you have to do it. Then there is a disclosure of information where there is proper diagnosis, treatment has been proposed, outcome has been probable, outcome has been selected. Then there are benefits and risks that have been discussed, alternative treatments have been provided, and the prognosis of the treatment, if it does not exist, has been provided, if not provided previously, that how is it is going to progress, what the doctors or the healthcare team or as a nursing individual you think the prognosis is or will be for this proposed treatment, and the condition of the patient. Then after that, you take your consent. After all these things have been discussed and appropriately disclosed to the patient, then the patient's competence has been assessed and everything has been explained to him. He has been able to understand everything. Then voluntarily the patient has consented for it without any coercion. Then it becomes informed consent. But without disclosure of all of this information and without assessing the patient's competence to be able to understand all of this that has been told, any kind of consent that has been taken will be considered consent that has been taken with coercion. So the voluntariness of this informed consent will go away, and it will not embody the idea of actual informed consent that should exist. Life-sustaining treatment, the factors that need to be considered as the constitutional rights of the individual or the family, the quality of life, the medical futility, ordinary versus extraordinary care that can be provided in terms of this, whether it's ordinary procedure, whether it's extraordinary measures that are being taken for this particular patient, and the impact that advanced technology is going to have. Or medical futility is basically when you're providing all of this, but you know in the end it's not going to be useful, it's going to be futile, it's going to be waste. So should we use these extraordinary measures or not? So that becomes a question. Ordinary versus extraordinary care. Ordinary is common, non-invasive, usual nutrition, hydration, antibiotics, tried and tested treatment. Extraordinary care would be complex treatment, invasive, new, experimental, and therapies that have not been proven previously, that are unproven therapies that are being used, unproved, and dialysis, ACLS, situations like these. What are the CPR issues that come up? Should a patient be coded or not? A do not resuscitate DNR order is needed, do not initiate a code. If it has not been given, you are supposed to resuscitate the patient. Advanced directives have been useful in guiding whether what you want to do or make decisions prior to the coding, and family presence during codes is promoted so that you are able to know whether the patient has to be resuscitated or not. Life support definitions, again, withholding, you're not starting the live by not initiating the treatment at all. Withdrawal, you're weaning or removing the treatment. Withholding, not giving it at all. No life support treatment will ever be given at all. You're not going to start it. Withdrawal, you are started it, you it to some level, now you want to withdraw it. That is weaning or removing it. Comfort measures are still maintained, supposed to be maintained. There are still debatable views on whether withholding and withdrawing of life support, what is the difference between the two, what to be practiced. But again, it is situational. It depends on the patient situation that has come to you as a nurse and as a healthcare professional member, and what is the action that the family and the patient and their surrogate that they have appointed together want to take regarding it. Helping families make decisions, you need to communicate frequently, engage in consistent, honest communication. Patients' wishes need to be supported in providing psychological support. Self-Determination Act is basically right to initiate the advanced directive ADR, whether they want to direct it or not, and the patient's right to consent or refuse to treatment. After understanding everything, not consenting. After understanding everything, giving consent. So either refusing or agreeing for the treatment, that is all the patient's right. Advance directives are the DNR patient sign, that is, or a power of attorney that they sign, giving another power or proxy or surrogate to take decisions about them. Also, making a will regarding what treatments they want to be given, what they do not want, wanting a natural death, anything. Communication preferences, anything can be a part of advance directive. Organ and tissue transplantation, any issue can come up in the brain death criteria, what to do. And do you want to donate organs? Do you not want to donate organs? The individual wants to, the family doesn't want the organs to be donated. Patient's designated view is contradictory to the family's view. So it can be very different. Patients who are brain dead are often candidates for good organ donation. So whether you want to do that or not, designated requesters seek consent, whether they want consent or not. So all of these issues can come up and become big ethical dilemmas while handling cases in critical care. So I hope you've understood the entire concept of the issues that the nurses can face in critical care while handling patients, and how they are supposed to approach them using the 4, 5, 6, 8 ethical principles that we discussed, all of them, and how they need to be truthful and justified in their choices and practice non-maleficence, beneficence, and autonomy while administering treatment and providing care. So that's it for today. I hope you've understood the entire topic. I'll see you again another day with another topic. Thank you.